Webcast, where we bring forward conversations that matter deeply to women entrepreneurs. I'm Dr. Srinidhi Chidambaram from Apollo Hospitals. This session, the webcast sessions are also presented by Apollo Hospitals, and I will be moderating today's session. Let me begin with an imagery. Imagine a woman who has built her business from the ground up. Her mornings begin with strategy calls. Her days are filled with negotiations. Her nights end with proposals, planning. She's celebrated for her resilience and admired for balancing ambition with responsibility. But yet, behind that strong exterior lies a quiet struggle, perhaps. She is navigating the uncertain and emotionally draining journey of infertility. Now, I'd like you to pause for a minute and think how many of us know someone, a friend, a colleague, perhaps even ourselves, who has silently faced this challenge. Infertility is far more common than we often realize, and yet it remains shrouded rather in silence. And it's not just a medical condition, it's also a deeply emotional, social, and human challenge. And this is something that we all need to discuss. The story is not about just one woman, it's about countless women who, while maybe breaking barriers in the world of careers and work, are often carrying this deeply personal battle about infertility, carrying that silence and stigma and uncertainty. That is exactly why we have curated this session this afternoon: Hope and Health, Infertility, Innovation, and the Power of Informed Women. At Webcast, you know that our mission has always been to create safe spaces like this, to replace the myths with understanding, to bring knowledge where there is confusion, and to build solidarity where there is isolation. Because no woman should feel that she has to choose between her professional aspirations and her personal dreams. I think we feel that she deserves the freedom to have both. So, to enlighten us today, we are privileged to have with us two leading experts. I first welcome Dr. Radhika Bajpai, who is the Joint Director and the Head of IVF and Reproductive Medicine at ApolloMedics Speciality Hospital, Lucknow, a specialist with deep expertise and compassion, who will speak about how science is opening new doors for women struggling with infertility. Dr. Radhika Bajpai, MD Obstetrics Gynecology with a diploma in reproductive medicine from the Kiel School, Germany, also holds a diploma in male infertility virtual preceptorship from Germany again, and a PDCC on fetal medicine with over 14 years of experience. Welcome, Dr. Radhika Bajpai.
Thank you, Dr.
While
Srinidhi.
infertility is often thought of only in terms of IVF or medications or egg freezing, many women also face underlying conditions that cause infertility, like endometriosis, adenomyosis, fibroids, blocked tubes, and adhesions. These require surgical expertise. That's where the minimally invasive and robotic surgery plays a game-changing role today. And I'm delighted and honored to welcome to this session Dr. Rahul Manchanda, who is a very senior and renowned Gyne-Endoscopic and Robotic Surgeon and head of the Gyne-Endoscopy Unit at the PSRI Hospital, New Delhi. A pioneer in gynecological endoscopy and robotic surgery, he will share how surgical innovations are improving the fertility outcomes. Dr. Manchanda is the head of the Gyne-Endoscopy Unit. As I said, he's an author with over 150 publications and 4 books, a board member of the ISGE, member of the advisory board of the School of Hysteroscopy at the Symbiosis University, Pune, a preceptor in robotic surgery for CMR UK, and a member of the AAGL special interest groups on hysteroscopy and endometriosis. So let's begin today's session with open minds, with open hearts, and the belief that when we come together, no challenge is too great to overcome. So let's begin by asking Dr. Bajpai to help us understand what is the real picture of infertility in India? What are the most common causes that you see? Let's first discuss about the women. What are the most common causes you see among women today?
So today, infertility, as we see, it is showing a rising trend globally also and in India also. If we talk about India, the according to National Family Health Survey report, which was published in 2021, the prevalence of infertility is around 18 per thousand women, which is roughly around 30 million couple being affected with infertility. And next, talking about the causes of infertility in women. So most commonly what we see is the ovarian dysfunction, which is mostly related to PCOD in the younger women. Then again, there is a X factor involved in several other cases, like in patients with endometriosis and patients with low ovarian reserve. Coming to the other causes, tubal factor is also very common, tubal blockage, which is often seen in patients with infections like tuberculosis being common in India, then also in cases with sexually transmitted diseases. Then there are structural malformations, which again hinder implantation process, leading to infertility. There can be factors like fibroid uterus or adenomyosis of the uterus or any polyp or adhesions distorting endometrial cavity. So these are the other common causes, but still there are around 20% such patients as we see who come to us with all their reports normal yet not able to conceive. So those patients we label them as unexplained infertility and go about their treatment.
So you were also saying that infertility is a growing phenomenon. What do you think is actually the reason for this? Though there are many structural and other endocrine and physiological conditions that might cause it. Why do you think this is a common cause now? And I also wanted to ask you that, what are the common myths that usually, are surrounded? Because usually when somebody has not been able to conceive, I think everybody, right from the person on the street to family and friends, venture an opinion. And it is a lot of comments are made about lifestyle or past pregnancy, some sort of, like as if it's something that could have been remedied. So, in your practice, you must be encountering a lot of these myths and beliefs as well. So, do enlighten us on what could be the cause of this growing trend of infertility, and also what do you think people should not really be looking at? What are the myths and misconceptions?
So, for the growing trend of infertility, yes, definitely the lifestyle changes that have happened in the decade or so, the working with the work culture, the sedentary lifestyle, the increasing incidence of obesity, and poor eating habits, substance abuse, all of this can be in a way correlated with the rising trend of infertility. As far as misconceptions go, so there are a few related to diet. Maybe this is the social conditioning as we come across. There are patients who come to us when I advise them high protein diet, then they specifically ask, and I tell them about, for example, egg intake or almonds or what they say is that their parents don't allow because these are sort of, these foodstuffs have by nature are hot in nature. So they ask me that whether or not we can take them. So, but there is no such scientific basis to it for not to take them. Then there is other spectrum where when patients with poor ovarian reserve, they come to us and they ask us about the any food stuff that can boost their egg count. More specifically, they ask about fruits like avocado or kiwi. Should they specifically take them? So I think all the fruits, fresh fruits, they are good and they have got good antioxidants and they boost our immunity, boost our general health, which is an extension, and an extension boosts our reproductive health. So you take orange or apple, you take avocado or kiwi, will not make a much of a difference. It will be just like it will improve your overall health. It may or may not improve your chances of natural conception, but then you need to you need to understand that if it is infertility, you need to consult a specialist. And another thing what comes across to me is quite often when we do post embryo transfer patients, that absolute bed rest to be taken post embryo transfers. So this is something which is even studies have said that the patients who are ambulatory, who are up and about, they have got a better chance with pregnancy outcome compared to those who are on bed rest. So these are certain things which we come about and we tell them about whether to be done or not.
There's also this thing that people, I guess, in terms of, like women who, have a later marriage, a later age of conception.
Yes,
Is
definitely.
that
Yes.
is that often considered to be a factor? which plays into this infertility. But I think that is inevitable, isn't it? Because I think women are getting
Yes, yes, over the years,
casualty of men
as I
are
said, in
getting
the
married
past few
later.
decades, definitely delayed marriages and delayed childbearing is one of the reasons. For sure, it is because with in advancing age, has been shown to be scientifically, it has been shown that there is a negative effect on the egg number and egg quality as well. So this somewhere down the line is a reason for women to have a higher incidence of infertility.
Dr. Manchanda, let me ask you this, not strictly related to your specialty, but I'm sure you have insights on this. So you must be interacting with a lot of professionals, students, young women who are coming to you for these gynecological conditions. What would you like to say that there are certain things that young girls or students or young professionals should be aware of as a possible future red flag for infertility? And is there anything that they should be doing to correct them early or so on, or is there no such thing?
So thank you very much for first of all having me here, Dr. Chidambaram and Webcast. Of course, my friend Anna Roy, who also asked me. Now, coming to your question, um, the first red flag that I see is we need to have both partners together. And in this world where we have professions and we do have our partners, but we don't tend to meet them. So that's the first thing that you have to spend time together. And if you don't spend time together,
Basic.
it's not happening. Having said that, let's come to the gynecological, a couple of red flags that I feel are important. One is, of course, your periods. So the periods, uh, pain during your periods, irregular periods. These all sort of can be symbolic of having an underlying problem, which again would then cause us what we call now more than infertility. And Dr. Bajpai will bear me out. We tend to use the term subfertility, which is again same thing, but we sort of use that term. So your period pattern is important. Lifestyle, I've said, of course, being with your partner, but heavy periods and irregular periods, delayed periods, uh, you're looking at underlying problems that can be there. Also, like I said, painful periods. And I'm sure you'll ask us more questions about these things. But these are some of the red flags that you have that people should take note of. And I think it's a good thing to once you're looking at conceiving, it's a good thing to visit your healthcare provider or gynecologist to sort of have a bit of a preconceptional where all they do is, or all we do is, would maybe take a history or chat with you and explain to you certain small things, like I said, of being with your partner and what is the right time to sort of try, and those itself will I think take care of a lot of problems. So that's important. A preconceptional when you've decided to go and visit your gynecologist would be a good idea.
Great suggestion. Dr. Radhika, I just wanted to ask you because today I think there's so much of news and awareness about all these terms. So, people use all these things like, ICSI and IVF and IUI. All these have now almost gotten into our daily conversations, but I'm not exactly sure whether our viewers might know exactly what they are. Of course, we don't have to go so technical, but if you can just explain in simple language what these different levels of treatment are, and then we leave the surgical for Dr. Manchanda to explain a bit later.
First and foremost, there are certain things that we need to know to decide what treatment modality to be adopted to what patient. So one obviously would be the cause that we get when we evaluate the patient. Then another important thing is the age of the female partner. and the duration of infertility. Then obviously the past treatment history, what treatment have they taken, what has been the reproductive outcome, has it there been any or not. And then obviously last one is the choice of the patient. There are times when male partner is in Navy, merchant Navy, or is in Army, so they are not staying together, as Dr. Manchanda said. So staying together of the partner is one prime requirement for them to conceive. So now, on the basis of these, we decide what treatment modality to be adopted for what patient. So first, if we talk about IUI or intrauterine insemination, it is a very low intervention procedure, can be done even in low resource setting, wherein what we do is we just stimulate the ovaries of the patient to get 1 or 2 good follicles. And when the follicles are ready, we trigger it. And then on the other side, around the time of rupture, we collect the semen sample of the male partner, process it, and then inject by means of a catheter into the uterus of the female. So when the indications are, what are the times rather when we use IUI for a patient? It would be like when it is unexplained infertility or mild ovulatory dysfunction or mild abnormality in semen parameters. Then at the time when the couple is not able to have intercourse, it is either pain during intercourse for the female or ejaculatory problems in the male. So these are some of the common times when we advise patient for an IUI. IUI overall has a success rate of around 10 to 15%, but nonetheless, it can be very well tried. Next, if we talk about IVF or in vitro fertilization, the word goes like in vitro means in the lab, where we do the fertilization process in the lab. Fertilization is making of the embryos. We make the embryos in the lab and then transfer the embryos in the uterus of the female. Now, IVF process is used when obviously if IUI failures are there, then we can go for IVF process. If the patient is having tubal blockage, then we have to go for IVF process. Or if it is cases of severe endometriosis or PCOD was not responded to previous treatment, all these times we advise for IVF. Then if male factor is severe, like around 5 million count or so, we can go for IVF. And then in patients of endometriosis or in patients where the patient is menopausal, her egg reserve is depleted. So in those cases, donor cycle plan can be done with the help of IVF. Now, next term is ICSI or intracytoplasmic sperm injection. This is one technique which is in fact a boon for patient where male partner has got severe semen parameter abnormalities or even absent sperms. So in those cases, we can even retrieve sperms, a handful of sperms from the testes of the male partner, inject it directly into the egg and fertilize and make the embryos. So this is ICSI.
Are there any other newer techniques as well which I might have left out?
Yes, can be other sperm sorting techniques which we may use, like we can use for better sperm selection, like PXC or MC. Then for fertilization, I think this is it, what we talk of in general.
Of course, we also know that all fertility challenges cannot be addressed just by these kind of ART therapies or by medication alone. So sometimes, as I said, the root cause may also lie in underlying structural and surgical issues. So, Dr. Manchanda, this is where we would like to seek your expertise. So many women usually assume that, surgery is some sort of a last resort kind of thing in infertility treatment. But could you please explain to our viewers when surgery also plays a role and where it fits into the overall fertility journey of a person undergoing treatment? And sometimes, they might, and what are the particular scenarios where the surgical intervention or an early surgical evaluation becomes important?
Okay, so yeah, I agree with you. Quite the contrary. Surgery is not the last resort. Indeed, it's one of the things that should be done to actually diagnose the problem and diagnose the way forward. Um, Now, how is that? If a couple comes to us and you need to treat each couple individually. So there's not one shoe fits all or one size fits all. You evaluate the couple, like Dr. Bajpai said, individually. So you look at the male partner, you look at the female partner, and then depending on where you have a problem, you try to treat it and then map your way forward. So a surgical or an interventional procedure, which is like surgery, which we call is a diagnostic laparoscopy and hysteroscopy. A hysteroscopy is looking inside the uterus with a camera, like we do a endoscopy for the stomach. Similarly, it's for the uterus, and laparoscopy is inside the abdominal cavity where you see the uterus, you see the tubes, and this way you do a complete evaluation of the lady. Once you see what the problem is, then you chart your way forward. Whether it's if your tubes are blocked, then you can try and open the tubes depending on if they can be opened. Diagnosing endometriosis, which I'm sure we'll talk about later. Diagnosing any other structural abnormality which might be the cause, or any abnormality, whether it's an ovarian problem, a tubal problem, or a uterine factor. You diagnose it, and then depending on where the problem is, if there's a problem, you try and treat it or correct it at the same time and chart the way forward. Whether it's like Dr. Bajpai said, you go in for an IUI, or if there's nothing that you can do, the tubes are blocked, then you need to bring the sperm and the egg outside, fuse them, and then put them inside. So it's a procedure that actually should be done, and we recommend it. It's written in our textbooks that if you're trying and having regular intercourse, and you're not conceiving and everything else is normal for a year, then you need to do what we call a diagnostic, which I've spoken about now, diagnostic hysteroscopy or a laparoscopy. Now, this again will depend on the patient's age. If the patient is above 30 or 35, then your time limit really is 6 months of trying regularly unprotected intercourse, like we say. And if you don't conceive, then you need to be investigated with a laparoscopy or hysteroscopy. And then finding the problem, you correct it and chart your path forward.
So this again, two terms which people often now we hear it more and more often is this endometriosis, adenomyosis, of course the PCODs, and the fibroids. So what are these? Again, I would request you to explain them to our viewers in a simple way, so that they can understand and also tell us how they can affect your fertility.
Okay, so I think this is my nowadays my goal and my passion is to get people more aware of this drastic thing called endometriosis. So let's take up endometriosis first. Normally, when the lady has her periods, what comes out as blood is the lining of the uterus, which we call the endometrium. Now, when this lining, these cells that are present in the lining of the uterus are abnormally present, say on the ovary or inside the abdomen or inside the muscle layer of the uterus, then when you're bleeding outside at the time of your period, you're bleeding by these cells also. These cells, the blood gets collected because it has no way of coming out. This is called endometriosis because when the blood gets collected, everything gets stuck together. So one of the signs or symptoms of this is to have painful periods. Unfortunately, in our country and I think elsewhere also, pain during periods has been normalized, which we need to tell everybody that it should not be taken as normal. If you do have pain during your periods and uh, your normal life gets affected, then you need to see your gynecologist, especially somebody who knows about this, aware of this disease, and try and exclude this. Because if this is caught early, you can effect as close to a cure as possible. So the key is to catch it early. And this can cause, of course, fertility problems because the anatomy gets distorted and you can have problems with that. Now, fibroids. Fibroids are basically tumors in the uterine cavity, or rather in the uterus, the muscle layer. And these can again impede fertility by maybe blocking the tubes or coming inside the uterus and causing obstruction at the place where the baby is supposed to be. So these again, depending on the individual person and the individual case, need to be dealt with generally surgically or with some intervention. So that's fibroids and endometriosis.
What about adenomyosis? Is that also quite common?
Yes, I said the cells lying inside the on the ovaries or tubes or inside the abdomen. I also said inside the muscle tissue of the uterus.
That's
That
the
is adenomyosis, and these can cause heavy bleeding, irregular bleeding, cloth passage during your periods, and of course, your quality of life gets disrupted completely. How many friends do I have or patients that I've seen who don't go to work, have a hot water bottle on their tummies? I'm sure there'll be people here who will relate to what I'm saying. And actually, I've seen patients, which is so unfortunate and sad, and you feel bad. They have burns on the skin, the tummy, because of the hot water that they put there, and we need to get out of normalizing such things. We need to say, and it's nice because nowadays I see people coming to me, and some of the girls, young girls, bring their parents that, I need to go and see this doctor or gynecologist because I have these problems. So there is better awareness, but we have miles to go before we sleep.
Um, Dr. Radhika, I think we will now discuss briefly about the other half, the male factors in infertility. Again, often somewhat overlooked and not discussed even more than the women's side. So how common are these factors in your practice, and how can they be diagnosed, and are there any ways to improve male reproductive health as well? Because we do hear about all those risk factors that hamper sperm production. So could you tell us a bit about that?
So male factor infertility is as common as is female. We almost get 50% patients of either male factor and female factor. And the one test that we advise for assessing male factor is the semen analysis. And if that is fine, we need not investigate husband further. But if there are some problems with the male parameter, then obviously we go ahead for, say, hormonal profile, some genetic tests or ultrasound or so. So the common times when we assess the cause of these abnormalities, most of the times we won't get a cause and we label it as idiopathic. But then there would be other times when conditions like varicocele or history of some genital surgery or history of infection like mumps. Then there can be history of exposure to gonadotoxic drugs like chemotherapy or certain other medications men use for bodybuilding, anabolic steroids. So this can also lead to low sperm count. And then these are the common things that we come across. Rarely there can be some genetic syndromes also which are associated with abnormal semen parameters or nil sperms. So this is how we go about it. And yes, evaluation part definitely not always is missing, but sometimes, especially when I go to peripheral OPDs in smaller districts, I do come across patients where female has been worked up, like rather overworked up with the tubal patency test and everything being done more than what is required twice or thrice, but not even a single semen parameter is available. So, and when you order it and you find the problem is in male partner. So this is what has to be, more awareness has to be spread, a word about this all across through public media, to social media platform, that yes, infertility is a disease of the couple and evaluation has to be done of both the partners simultaneously. Then, as I said, because the lifestyle factors which affect females have also affected male partner. Substance abuse is one very important thing, and then obviously the sedentary lifestyle. Obesity is again one thing which affects adversely the semen parameters. Poor eating habits, and there are times people work. The other day there was a couple who they work from evening 7 to morning 4. So this is the thing which the lifestyle has become totally upside down. So all these things need to be corrected when we uh, evaluate workup and advise our patients.
Right. We are getting quite a few queries live, as well as some have sent in. So I do want to give some time for that. But I am going to ask you, Dr. Rahul, to briefly tell us about this whole thing about the robotic and the minimally invasive options. So what is different from traditional approaches? And why should people, is there some particular advantage in going for these kind of gynecological procedures while getting evaluated for infertility and even otherwise?
So, now what is traditional surgery? Traditional surgery is making a large cut on your tummy and then going in and having a look, which you need to do, like I said before, in order to evaluate the lady. So, rather than having a large cut on your tummy, if you can do the same thing through small holes, it's much nicer, and that's called minimally invasive surgery, which I'm sure most of us are now familiar, and has literally replaced the traditional surgery where it's available, of course. Now, if you have smaller holes, the recovery is faster, the pain is less, you can get ambulated earlier, the bleeding is much less. Actually, you put in a camera and you see, so what you see is much more enlarged, like a magnifying glass. So you can catch even smaller problems and you can repair them or do whatever you have to do in the same approach. So, I mean, everything is better, including cost going down for the procedure. Because you have lesser medicines used, hospital stays lesser, and your recovery is faster. Now, robotic surgery is one step ahead of that because here, again, I'd like to tell everybody because people think that the robot is doing the procedure. Robot is not doing the procedure. It's merely a tool which is being handled by your surgeon, by your gynecologist, who's then going to do the procedure. So it's just a tool. And with the newer, latest news, I don't know if you've heard, but I'm sure Dr. Bajpai has heard, is about this robot uterus that has been made by China, and hopefully it should be in. I don't know if it's going to be in soon, where you'll have the baby being housed by a robot in a uterus in the robot, and women will not need to actually undergo and have pregnancies, and the baby will grow there. And so basically, I mean, there's a lot that's going on at the moment, and there are positives and negatives to either side. That the if so happens, the women will not have to have the problems of pregnancy or the complications of pregnancy, or we may not lose our mothers during childbirth. Those are just things that are happening. So robotic surgery is again minimally invasive surgery where you're using a tool called robot, where you have a three-dimensional vision. That means you have depth perception. Essentially, it makes your surgery easier, better, more precise than what even minimally invasive surgery traditional approach is. So these are advancements, and with AI coming in, it's going to be even more advanced. Rather, it has come in. The advantages that you have, for example, if you look at endometriosis, endometriosis is a disease which is deep inside the pelvic cavity. So the reach of a robot is much more than even traditional laparoscopy or minimally invasive surgery. The preciseness is more. So it does afford, it affords a lot to the surgeon who's doing it, the gynecologist, because it's more ergonomic. So the surgeon or the gynecologist is more comfortable, and when your surgeon is comfortable, they generally do a better job. So, uh, so definitely robotic surgery is there. It's coming in, it's come in, and it's maybe a shade better, but we still need to have studies that prove this. Having said that, the results are at par, if not better, with traditional minimally invasive surgery. So minimally invasive surgery is much better than traditional, which is having those large unsightly cuts. Also in ladies, for example, even for our younger girls, I have a girl who came to me who's 23, unmarried, and she has what suggests endometriosis. Now, if I open up her tummy, cut her tummy up completely, then it's more traumatic for her. And of course, you know how it is in our country. You have a large scar on your tummy, and so definitely minimally invasive surgery is much better in all ways for our ladies.
Right. Infertility isn't just a medical thing, but we also know that it's quite a emotional journey for women, for husbands, wives, and families. So how important is the other part of it, the psychological support or counseling? Does it exist in our country, and do you offer this to patients? And do you think there are resources where couples can reach out and seek help for their mental well-being?
Is that to me?
So
To
No.
anyone. Really?
Dr. Bajpai, you want to take it, then I'll talk a little bit on that
Yeah,
after.
okay, I'll take it. So, infertility we know is a medical condition, but it is certainly has got a lot of, psychological and emotional impact. In fact, there have been studies where it was studied that the psychic of an infertility patient versus to that of any other medical condition, and it was shown there that the infertility couple face a crisis-like situation, like that of a patient suffering from some serious illness like cancer or post-recovery of myocardial infarction, or even like losing the life of a near and dear one. So definitely infertility couple, they come with lot of burden on their head, and by ART norms we need to have a counselor in our ART clinic to support them through their journey. So one thing is very important. We have to be very empathetic with the couples who come to us. No matter what, we need to be, it's like, we need to be unconditionally positive, have a positive approach to them. Then there are times when patients face like real sadness or grief. At that time, counselor helps them express their distress, or at times counsel them slowly, bit by bit, rationally, to help them understand the cause of their problem. There are times when we do a cross consultation with a psychiatrist also, so that help them ease their problem. Now, coming to the medical part, we do have to respect the choice of the couple, what they want, and then help them arrive at a decision to what their treatment plan is going to be like. But at the same time, being an infertility professional, it is our, like, it is, we should try and strike a balance between what their personal expectation is vis-a-vis what the realistic approach would be, especially in the times of today where a lot of social media hype and misinformation. But then all of this is for sure has to be dealt with great sensitivity.
Absolutely.
So
I
we
mean,
have a counselor and a psychiatrist to help them tide over the problems.
I'm just going to read out some questions which are coming in from our viewers. We'll take a few of them before we go on to the subject of the surrogacy and the egg donation and the egg freezing aspects of infertility management. So this is from Shweta. She says, I have PCOD and I'm trying for 1 year. When should I consider IVF? I think we'll let Dr. Bajpai take it.
So has Shweta mentioned her age in this? And like I said, we need to assess the problem on various levels. If she's like young age, 25 to 30 years, the rest of the parameters are normal. Then we can even try with ovulation induction, and if the husband's part is normal, we can allow her with ovulation induction, try naturally. But then if this has already been done and her tubes are patent, we can allow her go for an intrauterine insemination. And if this is also not working, then yes, she has to go for IVF or IVF or ICSI, whatever the condition is.
Here's a question from Amisha. Are there any clear signs in our period flow that tells us it could be endometriosis, or is it just about the pain that we feel? Dr. Manchanda, would you like to take this?
You know, first of all, thank you for your question, Amisha, because it's important to create the awareness. Um, Periods or symptoms will not diagnose endometriosis. They will lead us to a doctor who will then try and diagnose if we have that. The diagnosis of endometriosis is made on laparoscopy. You have symptoms, you do investigations like an ultrasound that will help us maybe make a provisional diagnosis, but a laparoscopy is the gold standard for diagnosing endometriosis. But these symptoms that you mentioned, Amisha, which is painful periods, especially those that lead to decrease your quality of life, heavy periods will need to be investigated so that we can rule out the person having endometriosis, which is very important.
Right. Here's one from Sanika. What lifestyle habits and precautions should someone in their early 20s adopt in terms of diet, exercise, sexual health in order to prevent infertility? Either of you.
So one thing would be just for lifestyle goes, definitely you have to have a physically active lifestyle. At least try and have some amount of activity, maybe aerobics or walking or so. So but if the weight is high, try to cut down on weight. Have a daily routine, normal circadian rhythm. At least have 7 to 8 hours of avoid substance abuse, have healthy sexual practices, anything, avoid high risk behavior that can lead to sexually transmitted diseases. And yes, this is for females, and for males, yes, obviously there are other things like drug exposure and exposure to environmental pollutants and all. So with diet, with weight maintenance, and with regular lifestyle, one can to a certain extent avoid infertility.
Here's another question from Agam, who is from Lucknow, actually. She says, what could be the possible reasons my IVF cycle did not succeed, and she's 37 years old?
So when such a question comes to us, actually we need the whole backup. What all were the factors? So for our IVF success, what do we need? One is a good, healthy, grade A, what we call a best quality embryo, a good endometrial lining. So were these like the optimal parameters? Were they available? If not, then obviously, if yes, then we look for a little deeper in to look for the other causes. So if the embryo is good, if the endometrium is healthy, then, and if still patient has failed, then we have to probe other causes. Like what could be, had there been some problem with the tubes which was earlier not diagnosed, or a small polyp, we can go ahead for a hysteroscopy to see some undiagnosed factor inside the uterine cavity. Then male factors, there are times when something which is known as a high DNA fragmentation index, which usually routinely is not tested for, but we do additional tests in case we get a failure despite everything being normal. So now from here onwards, she needs a further detailed, deep dive into the factors, which would help us realize that yes, something was missing and what further we can do in her case.
Is that also true, doctor, that IVF cycles, like you'll have to do at least a couple before there is a success reach? There's also a belief like that. Is there any evidence to say that you have to do at least a minimum of 3 or 4 before we can conclude?
See, as the world literature says, the standard success rate of an IVF cycle is around 30 to 40%. In good scenarios, we have even seen like around 50%. But then, so there would be a category when one falls in this 30%, there would be a time one falls in that 70% negative. So it is not always true. There are, as I said, there are factors that we need to look for. If patient is positive, well and good. If not, then we further evaluate deeper for other causes and other factors that can be, and then go ahead.
Here's a question from Vedant. If male infertility is diagnosed, what are the first line treatments you usually suggest?
See, as for male infertility, as I said, what are the semen parameters? Actually, there is a WHO standard values that have been set, and we compare these to those. So, if depending upon the semen parameters, if it is like mild derangement, we can go for intrauterine insemination. But if it is severe, like less than 5 million or less than 1 million, we have to go for in vitro fertilization or ICSI. Or sometimes, if the morphology or motility and these factors, then we have to use along with ICSI advanced sperm sorting parameters, sperm sorting techniques. It could be PXC, it could be MC, and it could be microfluidics. All of this can be used additionally.
Just wanted to ask you also, before we go on to some more questions, because now people talk a lot about both people who are unable to conceive with their own eggs. They do have egg donation, and then they have this whole surrogacy, and there's also egg freezing, preserving sperm, so that whole spectrum of things. So could you give us a kind of a brief overview on what these are and what are some of the legal aspects that people should be aware of, because some of them are quite prone for misuse?
So let's first talk about egg freezing. So now egg freezing is a way of securing your fertility when you think it is at risk, at danger in near future. So what we do in egg freezing is, and let's first talk how when it is required. So in the conditions where patient is already around in her 30s and she doesn't want to plan a pregnancy in near future, wants to delay it for whatever personal reasons, we can freeze her eggs, and then later on, whenever she is ready, she can make the embryos and have the pregnancy with those embryos frozen at a younger age. Because as I said, with the advancing age, the egg quality and the number goes down. So one is the social aspect where, because of patient's personal issue, she doesn't want to have pregnancy right now and freezes her eggs. Then there can be medical reasons also, one of which is patient undergoing cancer treatment. So before going ahead for chemotherapy, she can get her eggs frozen, take the treatment, and then plan pregnancy later on. Because chemotherapeutic drugs are also very gonadotoxic. Then other thing can be in cases of endometriosis, like endometriosis is very detrimental to the ovarian reserve. So in patients who, and it is a progressive disease, it doesn't, complete cure is possible in very, very rare conditions. So if it is a case of endometriosis, we advise them either to have a pregnancy or at least get your eggs or embryos preserved, so that you can, whenever you are ready, you can plan your pregnancy. Then there are certain autoimmune conditions also, or certain genetic conditions also, where egg reserves, it can be depleted because of the condition or the treatment required. There also we advise patients egg freezing. So this is about egg freezing. Then we come to next part, as you asked, about egg donation cycles. So now egg donation cycle is considered in women who have already got their egg reserves depleted. It could be menopausal women, it could be women with premature ovarian failure, or at times there are when patients with poor ovarian reserve who have got several failed cycles, we can give the option of egg donation cycle to such women also. And obviously, the ART Act that came into 2021, they have laid down strict norms to be followed when we go out for a egg donation cycle. We need to secure the interest of the donor by having an insurance, providing an insurance cover to her. Then obviously, all the documentation consent part done. Then we select the donor for the patient, make the embryos with the husband's sample, make the embryos and transfer it into the uterus. And it is in fact very accessible, very safe, and very much acceptable. The patients who come back to us with a baby from a donor or from the cell, they're equally happy. It doesn't make much of a difference. And it is not uncommon, like 10 to 20% cycles that we do are of a donor egg cycle. But last thing that you asked was about surrogacy. So surrogacy is something when, for whatever reason, a woman is not able to carry her baby in her uterus. In that case, she transfers the embryos into the uterus of a third party or other woman who would carry the baby on her behalf and give the baby to her post-delivery. Now, again, this surrogacy thing has been, I think, has been misused in the past. So government is very strict when we go ahead with the surrogacy. There are certain things to be considered by the commissioning couple and by the surrogate also. So by norms, when somebody goes ahead for surrogacy, she has to get what is called eligibility certificate from the board, that yes, for the said and said conditions, which could be absent uterus or damaged uterus, or even suppose a woman has some medical condition because of which if she carries the pregnancy, her life would be at stake. Instances of like multiple implantation failures or pregnancy losses. So these are the times when she can go ahead for the surrogacy, and she'll get she will fit in the criteria. And one more thing, if any couple who has got at least one child, biological or adopted, mentally sound, then they cannot go ahead for surrogacy. As for surrogates, and yes, one more important thing, that a couple has to get an insurance cover for the surrogate for a set number of time to cover her pregnancy or delivery or postpartum complication. As for surrogate, she can only be a surrogate for once in her lifetime. Then she cannot be a surrogate with her own gametes, and she has to be in a set age like 25 to 35 years. So this is on the part of surrogate. So these things are being strictly followed, and government is very strict to it. And one more thing, the surrogacy has to be done with an intent of helping the commissioning couple. It should not be for any financial gain or motive of some hidden interest. So these are important points that need to be understood in an ART clinic and going here, practicing surrogacy.
And then it's also important to choose the right ART clinic, which is providing medical care. Yes. There's another question here from Priya, who asks whether missing periods, that is amenorrhea or skipping the period, will that lead to long-term damage of fertility?
See, can I take this, Dr. Manchanda?
Yes, please.
Okay. See, missing of periods can be because of so many reasons. It can be, there was a time, I would tell you a case where patient were told that doctors told her it was PCOD, but actually it was premature ovarian failure. So there are times we obviously, if she's missing period and she's missing it quite frequently, she need to go to her gynecologist and get herself evaluated as to why it is happening.
Okay. Another question, a lot of questions coming in thick and fast now. So from Muskan asking, how reliable are home ovulation kits as compared to the tests that you do in the clinic?
Well, I usually don't advise home ovulation kits because what I find more reliable and more convenient for us and as well as for patient is the transvaginal ultrasound to track the follicular growth and rupture. Because with home ovulation kits, one is it is actually costly, and then it has to be monitored in a certain way to be able to pick it up at just the right time when the ovulation has occurred. So, which is not always possible. So if you can read the instructions and go and you get it right, then it is okay. But I think it is better to go ahead for an ultrasound, which is a easier way and more convenient for you as well as doctor, who will guide you in a better way than home ovulation kits. But anyway, it is a way, and if you want, you can use it.
I think this we will give to Dr. Rahul to answer. So he's asking, Sukesh is asking if age affects a man's fertility the way it affects women.
Now, actually, a question for Dr. Bajpai, being infertility, but let me say aged. I will pass the question to her. But having said that, yes, I feel depending on the age, it doesn't affect to the same extent as a lady. Ladies are probably more susceptible to changes as far as age goes, but yes, it does affect age depending on not to the same extent as a lady, but it does affect. And I asked Dr. Bajpai
Yes,
probably
I
to.
completely agree with Dr. Rahul. Yes, this is what it is. It does affect, but but certainly the effect of age on women is more than that what it is on men.
I think we're really running a bit out of time. So let me just look at the other questions from our viewers to see. Oh, yeah, this one. How do autoimmune conditions or thyroid disorders play into fertility challenges? We haven't discussed that. So
So,
maybe.
if autoimmune condition is in, like, there are several autoimmune conditions which, if they're in control, then usually they do not affect fertility. But if the condition is in flare or it involve other organs like kidney and all, then because of their chronic nature of the disease, they might affect ovarian reserve and bring down the egg count. Then another aspect to it is like it can the treatment part. Sometimes the disease flare makes the doctor give you immunosuppressants or chemotherapy, which in turn has got a negative effect on the ovarian reserve and would cause infertility. Point number two, that autoimmune conditions have got a lot of pregnancy complications also. So there is a high chance of pregnancy losses in patients who are having autoimmune condition. So this way it affects fertility and take home baby kind of thing. Next part, thyroid. Thyroid usually in when it is very much deranged, it would cause menstrual irregularities because of anovulation. But other than that, thyroid, if it is controlled, which can be very easily be controlled on thyroid replacement therapies, usually doesn't cause that much of a problem, I think.
I think I'll conclude with one last question. Are there complementary approaches like yoga or anti-inflammatory diets and other therapies that actually have real clinical backing in improving outcomes? I think this is an important question because there's so much of interest now in alternative treatments like Ayurveda or uh, acupuncture, homeopathy, and there's also all those other things like yoga and stress management. So what do you have to say about these things? Is there any research which actually says that, some of these help in improving fertility?
Not that I know of. What I would say here is that definitely for alternative medicine, I don't know of the research or the studies that are available. But yes, for yoga or for stress management, definitely these processes can regulate your hypothalamo-pituitary ovarian axis, which is important for normal hormonal balance and normal ovulation pattern and cycles. So this, if does no harm, you can avail it. But as for alternative medicine, you need to find the evidence whether it should not affect negatively at least.
So yeah, Dr. Srinidhi, if I might add my two bits,
Yes.
I would agree with Dr. Bajpai that But yoga and all these alternative treatments that decrease stress, and stress definitely can cause issues with conception. They might add to them. So I don't think there will be any harm in sort of following yoga to de-stress yourself or other things. But I'm sure she and me, being men of science, uh, when we look at allopathic treatment, one would sort of do our own thing. But if anybody wants to practice yoga at the same time, I wouldn't stop them from doing it.
Right.
That's a good stand to take. So thank you so much, Dr. Manchanda and Dr. Bajpai, for taking all these questions so patiently and explaining to our viewers. As we come to the end of today's conversation, I want to leave you with this thought. As women, entrepreneurs, as career people, you have built businesses, careers, created opportunities for yourself and others, and you must have balanced countless responsibilities. But amidst all these deadlines and pitches and achievements, I think your health and your personal dreams for your family should never be at the cost of your career. So it's important to pay attention. And like any other, infertility is a condition. And today there is such great advances made in medical science and innovation that's helping us to overcome all these challenges. So I think it's very important to take time off from your busy schedules to take time to understand and analyze the challenge of infertility which you or your loved ones may be facing, and understanding your body and seeking the right medical help at the right time. So, to every woman who's listening today, I would only say take charge of your health, your reproductive health, because it's not because the world is telling you that your time is running out or that your biological clock is ticking. It's not that. But I think it's important to have that knowledge, because that gives you the freedom, that gives you the freedom of choice, that gives you the freedom to plan your life, and that also gives you the freedom to live life at your pace. So here's to informed women, empowered choices, and to every one of you who's redefining what it means to be a leader and a woman. So thank you so much for joining us. And thank you once again, doctors, for this wonderful, illuminating session. On behalf of all our web viewers, thank you so much. Namaste.
Thank you
Thank you
very
for
much.
having me.
Thank you for having us.
Thank you.